I would like to welcome everyone to our webinar titled Telemedicine Improvements After Epidemics Collide. My name is Dr. Kristin Hillman, and I am a member of the clinical team at Aegis. This is a brief educational webinar to discuss some of the regulation changes regarding telemedicine that have impacted patients with opioid use disorder, all thanks to the collision of two epidemics. The material presented here is the sole propriety of Aegis Sciences Corporation and may not be reproduced without express written consent. The takeaways from today's webinar include a review how the use of telemedicine has evolved over time. We'll discuss how flexibilities in telemedicine regulations changed medication prescribing for opioid treatment programs. We'll discuss how clinicians at opioid treatment programs have responded to the regulation changes in telemedicine. And lastly, we'll discuss how the use of drug monitoring has changed with telemedicine in this setting. Telemedicine, or otherwise known as telehealth, utilizes telecommunication technologies through audio or audio-visual, real-time, two-way communication to provide clinical services to patients outside of clinical settings. Before the COVID-19 pandemic, efforts were made to increase access to telemedicine, especially for those struggling with opioid use disorder during the rising opioid crisis. According to the NIH, opioid use disorder is defined as the chronic use of opioids that causes clinically significant distress or impairment. Symptoms of this disease include an overpowering desire to use opioids, increased opioid tolerance, and withdrawal syndrome when opioids are discontinued. In the US, there have been 3 waves of the opioid epidemic since the 1990s. First with prescription opioids, second with heroin, and third with fentanyl. The opioid epidemic reached its peak in 2017, with more than 47,000 opioid overdose deaths in the US that year alone. Efforts were made by the DEA at this time to improve accessibility to telemedicine and to address the country's opioid and substance misuse epidemic. However, there were very few opioid treatment programs who took advantage of these expansions to use telemedicine. Then in 2019, the COVID-19 epidemic collided with the opioid epidemic, and everything changed. The COVID-19 epidemic significantly impacted those with opioid use disorder because access to healthcare and social care was not as available. Because of this, individuals experienced social isolation, an increased likelihood of using opioids when they are alone, and increased mental health challenges. The NIH documented that the national drug overdose rate in the US escalated from 70,630 in 2019 to over 91,000 in 2020, many of which included opioid involvement. This certainly marked the harsh beginning of the COVID-19 epidemic. In response to the COVID-19 public health emergency, which was declared on January 31st of 2020, the DEA granted temporary exceptions to Rule 42 CFR 8 to implement the practice of telemedicine for patients with opioid use disorder. There were several exceptions, and this discussion today will specifically focus on the changes in buprenorphine and methadone regulations. As soon as March 16th of 2020, the DEA permitted buprenorphine to be prescribed through audio-visual telemedicine. And just 2 weeks later, the DEA relaxed this policy further to allow an audio-only connection. In the following month of April, SAMHSA, which oversees opioid treatment programs, issued comparable telehealth prescribing guidelines through exceptions to the Ryan-Haidt Online Pharmacy Consumer Protection Act of 2008. Originally, the Ryan-Haidt Act required most practitioners to have at least one in-person evaluation before prescribing controlled substances. The change that was made to the Act specifically allowed opioid treatment programs to initiate patients on buprenorphine through telehealth without first having an inpatient evaluation. Temporary exceptions also allowed for opioid treatment programs to provide patients with unsupervised take-home doses of methadone, a Schedule II controlled substance. The exception allowed all stable patients in an opioid treatment program to receive 28 days of take-home doses and up to 14 days of take-home doses for those patients who were less stable, but who the OTP believes can safely handle this level of methadone. These flexibilities were crucial because methadone treatment is associated with a reduced risk of illicit opioid overdose death. Lastly, the exemption did not allow for the actual prescribing of methadone through telemedicine, as it did for buprenorphine. 3 years after these temporary exceptions were granted, SAMHSA concluded through several studies that there was sufficient evidence that they had enhanced and encouraged opioid treatment programs through telemedicine at a time when we were seeing fentanyl-related overdose mortality spike. States, opioid treatment programs, and clinicians all reported that the opioid treatment program use of telemedicine increased both treatment engagement with patients and improved patient satisfaction with relatively few incidents of misuse or medication diversion. Utilizing telemedicine not only protected the public's health, but it also reduced the risk of COVID-19 infection among patients and providers. Here are some of the benefits that were identified through the clinical studies. Telemedicine is quicker and saves time and is less costly for both the patient and the provider. Patients who are unable to attend in-person meetings due to a lack of transportation are now able to access healthcare through telemedicine. Patients who require childcare, have to take time off of work, or have to drive a considerable distance can now have a meeting with their provider without all of these hassles. Telemedicine improves monitoring and maintains continuity of care, and there's an opportunity to have more frequent visits due to increased flexibility. Some providers noted that by seeing their patients in their home, they were able to have a better emotional connection with their patients. Telemedicine initiation was associated with better retention in buprenorphine treatment, and there were also health outcomes that were improved and overdose deaths that were reduced. Conversely, this is a list of concerns that were found. You can see how much shorter this list is compared to the list of benefits. Obviously, it may increase patient risk and liability. Diversion and overdose risk could be more possible due to having a larger supply of medication at home. The patient demographic that may not have access to a computer and/or the internet may not be able to utilize telemedicine. These patients tend to be the ones who often need the most help with opioid use disorder. And the quality of care may be limited due to what we have just mentioned, and also due to not having an in-person meeting. After documenting the benefits, in February of 2024, the U.S. Department of Health and Human Services, SAMHSA, and the DEA finalized Rule 42 to provide permanence to the telehealth flexibilities created during COVID and to introduce a new flexibility into the regulation. The rule was effective April 2nd of this year, and the compliance date will be October 2nd, 2024. And you can see that the discussion we had about the buprenorphine and the methadone are now permanent. So it is possible now to initiate treatment and prescribe through audio only or audio-visual telemedicine, and it can be done without an initial in-person exam. For methadone, they are still allowed to receive 28 days of take-home doses for stable patients and up to 14 days of take-home doses for those patients who are less stable, but who the OTP believes can safely handle that level of medication. One addition to this rule, which is now permanent as well, is opioid treatment programs can now initiate treatment and prescribe methadone through an audiovisual telemedicine without an in-person exam. SAMHSA did state that an audio-only telehealth visit is not an option for methadone due to its higher risk profile. They like the idea of being able to see the patient and to be able to tell if there's any excessive somnolence. The final rule also expanded who is able to prescribe and initiate MAT, including physicians and nurse practitioners. If states have more restrictive regulations than the federal final rule, which is what we have discussed, then unfortunately those patients in those states may not benefit from these federal changes. Several studies found that the OTPs that utilize the new telehealth flexibilities allowed their urine toxicology testing to be used less frequently or waived completely. Opioid treatment programs have expressed concerns over the potential increased risk and negative consequences for the quality of OUD care as a result of less frequent drug monitoring. OTPs have established that drug testing assists opioid treatment program providers in monitoring adherence to the prescribed medication, detecting substance use that could complicate treatment response, and monitoring for possible medication diversion. Without the information from toxicology testing, there is a substantial amount of information that is being missed to properly care for patients with opioid use disorder. Toxicology testing is recommended throughout OUD treatment, including both maintenance and recovery phases. Aegis Sciences offers opioid treatment programs and all providers the ability to perform observed oral fluid sample collections remotely during telemedicine appointments using the Aegis Remote Telemedicine Solutions. Continuous medication monitoring throughout treatment utilizing telemedicine improves the quality of care for those struggling with opioid use disorder and decreases risk by measuring an individual's prescription compliance and substance use. Aegis's oral fluid testing utilizes definitive testing. Oral fluid is an accurate alternative to urine with an expansive menu, including up-to-date novel psychoactive substances. A complete list of Aegis test offerings is available through your local Aegis representative or by emailing info@aegislabs.com. The references included may be accessed in the written clinical update, which is available at our website at aegislabs.com. If you have any questions specific to today's webinar or any general questions, please feel free to call or email the clinical team using the information at the bottom of this slide. Thank you for your time and attention, and I hope that you have a great rest of your day.